Hello and welcome to Benefit News. You're here with me, Marilyn Gore, and this is the Wellness Benefit Podcast. Today we're talking about something that affects almost 1 in every 5 women. And scarier than that, 70% of those who have this go undiagnosed. We're talking about Polycystic Ovarian Syndrome, also known as PCOS. There's an issue here with the name itself, because not all women who have this have cis. And there's lots more to unpack in this disease, in this syndrome. And to help us with that, we have today with us Dr. Harsh Desai. He's an ObGyn, and he is here to answer all my questions and hopefully some of yours as well.
Thank you.
Thank you for joining us, Doctor.
So just to add one more thing, it is 70% undiagnosed and it is 90% overdiagnosed as well.
Okay.
So there's another side of the story where people not having PCOS have moved on many years in their life assuming they have PCOS. So it's both ways.
So not all missed periods are PCOS.
Exactly.
Okay, we've heard PCOS and PCOD. What is the difference?
So PCOS and PCOD are just two sides of the same coin, but broadly speaking, PCOD is something which is restricted or is only an aberration, abnormality of the hormones. Whereas when you go into the PCOS, which is Polycystic Ovarian Syndrome, it's the hormonal plus there are so many other metabolic conditions like abnormal lipids, raised body mass index, sometimes diabetes. So there are a number of other metabolic conditions that are added into the whole thing.
Symptoms as well, right?
Yes.
I think hirsutism is one.
So there could be both. There could be hirsutism. There could be alopecia.
Okay.
There is something known as acanthosis nigrans, where you have these
black patches.
Yeah, in the crease of your skin. You'll see some girls who are like 13, 14 who are overweight. They're pretty fair, but when you look at their skin creases,
I thought that was a symptom of diabetes.
No, acanthosis is so diabetes in young girls most likely is a result of insulin resistance.
Okay.
Hence there is hyperinsulinemia. Hence it happens. Insulin is an anabolic steroid. Hence this whole thing happens. So here in polycystic ovaries again, there is a cascade or there is a part of the disease which affects the girl's insulins. Hence the hyperandrogenism, more male hormones, less in comparison to the female hormones. So when you go into the trying to understand what PCOD or PCOS means, you need to first understand that a man is a man because he has testosterone higher than estrogen. It's not that he just is androgenic and he doesn't have any female hormones. At the same time, a girl is a girl because her estrogen is much higher than the levels of testosterone in her body. When these checks and balances start changing, that is where the whole disease or syndrome or condition starts. It is not a watershed line where below the line the girl is normal and when she crosses the line she suddenly becomes PCO. PCO is a spectrum. It starts small and then it starts building on it. It starts getting worse and worse and worse, and then the ovarian structure, the whole physical structure of the ovary start changing, and hence then they go into something which people would dare say is irreversible, or there'll be long-term sequelae of it. Most girls, if diagnosed early, would be benefited in the long term. At the same time, most girls who are falsely diagnosed, if informed and educated early, would also help them going forward into their life.
So is this only important for people who are trying to conceive?
Not at all. PCOD is not a disease. For infertility is like the least of their problems.
So what else?
And science today is thankfully at a point where most major factors affecting infertility can be addressed and addressed pretty effectively with good results. So infertility is a concern, but it is the least of your concerns.
Because quite often that's where we hear about these coming in.
Yes.
A lot of women, especially of childbearing age, suddenly decide that they have PCOS. I will say decide
Well
on
said.
purpose here.
Yes,
Because
they
it's
decide.
not always.
It's not a doctor telling them you have it. It's probably Instagram and the Googles and now the AIs of the world telling you, okay, so your BMI is 25 and you have pimples and you have unwanted hair and your cycle is a little off. And when you were young, an ultrasound told you have multiple cysts in your ovaries and you're stamped as polycystic ovaries. Then you say polycystic ovaries is a disease of lifestyle. Somebody tells you, the whole Google Gyan tells you that.
And every other auntie.
And every other auntie. So they will think, okay, so if it's a lifestyle disease, I might as well try and address it with just another
Not
Google
medical.
Gyan, not meeting a specialist for it. I'll try and Google myself out of it. And that's where the whole cycle starts. Just you informing me right now a few minutes ago, methi helping.
Yeah.
So these are the kind of things that people start going into. Sometimes even far worse, start abusing prescription medicines being taken over the counter because your friend took it and it helped her and this, that and the other. So here's how you are actually sliding down, and it's a slippery slope where you will go into an abyss, never ending abyss. But if you take medical help, either one of two things will happen. Your doctor will tell you probably are not PCO, which is the best outcome. And if you are, the doctor will be able to assess what is the gravity of the disease. Is it here? Is it here? Is it here? And would be able to give you the right picture as to what to do, what are the corrective measures, what are the therapeutic measures, and what to look forward to into the future with your, the whole planning of your life and childbearing or your old age or postmenopausal age or everything else. Your general health as well. So polycystic ovaries cannot just be reduced to something that affects fertility. It affects the whole, the whole gamut of menarche to menopause in a girl's life. It's not just restricted to those childbearing age.
So it's basically from the time you get your first period till you get your last, and then some.
And then some as well. Because
menopause is 1 year after you get your last period, right? That is the rough definition.
So, okay, we can digress a little. Menopause is, poetically speaking, is your uterus stops responding to your hormones.
Okay.
Or on the other side, your hormones are so mild that it stops being effective to the menstrual dilating of the uterus. The uterus is not an organ of menopause. It goes into menopause.
Okay.
But the ovaries take it there. So when your estrogen and progesterone, your primary female hormones, decline to a point below a plateau where it is now no longer affecting the uterus, that is when you start, you cease to menstruate. And then you figure that, okay, this is like the mirror telling you, okay, you look pretty today, but the mirror stops telling you that. And then you realize, oh, I've gone old. So that is how menopause is assumed by community. But menopause starts probably a couple of years before that, and it's a never-ending process.
So you're always in menopause, right?
Yeah, and your estrogens never touch the baseline. Even a 55-year-old lady is still generating a certain amount of estrogen, however nominal.
Okay. Which brings me back to another question: is are all cysts bad? Like if there are cysts,
What do you mean by bad?
No,
They're an abnormality. But
do they necessarily mean PCOS?
No. So here's how it is. Any
Because
girl,
you were talking about
you take a girl who is 13, 14, who's just started menstruating. For the first 4 to 5 years of her life, if you do an ultrasound, they will show multiple ovarian cystic lesions. They are not necessarily polycystic ovaries. They're often misdiagnosed as polycystic ovaries. When a lady ovulates, the egg that grows reaches somewhere to the range of 25 millimeters in size, 2.5 centimeters. So that itself is a cyst, but that's the kind of cyst you want. But generally speaking, what we as doctors refer to as cysts are those large lesions in your ovaries, which are like 3-4 centimeters and above. They are causing you pain. They could be hemorrhagic or endometriotic or simple hormonal or malignant. Those are the ones which we are bothered about. When you say polycystic ovaries, they're all small. To give an image, it is like a queen's necklace, pearl necklace. So the ovary is like studded with small, beautiful, it actually beautifies the ovaries, but also comes with it some hormonal disturbances. But it's like a pearl necklace appearance of the ovaries. They're not large. They might be 2.5 centimeters each tops, not larger than that. But because it physically is studded around the ovary does not have space to ovulate. So most likely when they reach a point of really high level of polycystic ovarian syndrome, the ovulation stops. Hence the infertility that follows.
But symptoms for this are all over the place, right? You mentioned alopecia also, hirsutism also, weight gain also. So what else is there?
So
and why?
The diagnostic criteria tells you irregular menstruation. Now, to know irregular menstruation, regular menstruation means anybody who menstruates with a frequency of somewhere around more than 21-22 days or less than 35 days, right? If anybody is menstruating with a frequency of more than 35 days, then that would be considered as the early changes. Here, please note, we are not talking about adolescent girls whose hormones are still maturing. The first 3-4 years of their life, let them be. The most you can do is probably get them to meet a doctor, but don't try and tamper with their hormones. But I'm talking about a young girl, an adult. Anything more than 35 days, you would start thinking. Okay, so that being the first criteria that should bring you to a doctor. Obesity or weight gain, that is another criteria that should be taken into account. The skin changes, and when I say hirsutism, it is unwanted and excessive hair growth from the goatee to sometimes on the chest, on the abdominal wall. Alopecia would be the male pattern of balding and losing weight, losing hair, the black patches, pimples. These are the kind of changes that should trigger a question in your head. And finally, what is the gold standard? So the gold standard for diagnosing PCOS, along with the other things that I just mentioned, is your imaging, which shows you the ovarian cysts or the pearl necklace appearance, and associated with the most important being your hormones. Unless the hormones are tested, nothing else matters. The most important diagnostic criteria for somebody who suspects they have PCO should be a combination of this plus hormones. There is a criteria as such which is prevalent, which says of at least abnormal hormones to ovarian cysts to irregular menstruation, you should have at least 2 of them.
Okay.
So between irregular delayed menstruation and ultrasound imaging saying you have this and abnormal hormones, you should at least have 2 of them, and you should have abnormal hormones most likely to be diagnosed at somebody at some point in the spectrum of PCO.
Which hormones are we talking here?
For a girl, I to my patients, this is how I tell them that the hormones in your body are like a huge orchestra playing, and your pituitary is like Mozart trying to put them in place. And even if one flute or one violin goes out of tune, out of sync, there goes your music. So in the same way, there are multiple hormones that affect, but the loudest one of them being estrogen, progesterone, and to an extent testosterone.
Okay.
Right? So what we like to do is we like to go a step above and test the hormones, which in turn are affecting your estrogens and progesterones. More likely estrogen, which is your follicle stimulating hormone, and your luteinizing hormone. Most women know it as FSH and LH, which again Google tells you is the diagnostic criteria, and yes, it is. So we like to test FSH, LH, your estrogen. your testosterone. Some labs do good free testosterone as well, so you can do your free means not free.
I figured.
Free means, yeah. Okay.
Free as in free agents.
So free testosterone being done in sublabs, which are effective, but you can generally do your routine testosterone. There is an androgen which is released from the kidneys, your adrenals, which is called DHEA, dihydroepiandrosterone. So that is also something that needs to be tested. Prolactin is a hormone which works during lactation, right? But it mimics the symptoms of irregular menstruation like PCOD. So when you test, you need to do your prolactins as well, because if your prolactins are abnormal and your FSH/LH is normal, then your irregular menstrual cycle and your cysts that you observe in your ovaries are not because of PCO, it is because of hyperprolactemia. So prolactin is something that we would like to test. Yeah, mota, and insulin, your free insulins, fasting, your lipid profile.
Lipids में इसमें क्या लेना देना?
Lipid profiles are affected by your testosterone.
Okay.
Also, when you want to differentiate between polycystic ovarian disease and syndrome, it's the lipid profile which will tell you whether there is a metabolic syndrome at play here or it's just restricted. If it is a metabolic syndrome, I am more likely to offer hormonal treatment. If it is just an early disturbance, then I might try with some non-hormonal therapies and some lifestyle corrections that might be beneficial. Only time will tell. We keep the patient on a 3-monthly follow-up and see the girl.
Okay, so 2 questions here. When you say hormonal therapies, what do you mean? And second, can you work around PCOS with just diet and exercise?
To answer the first, the hormonal therapy that we offer is a combination of cyproterone acetate, which is a form of antioxidant, along with progesterone, which in coordination helps reduce the luteinizing hormone, improves your estrogen, and helps your PCO. Society misconstrues it to be an oral contraceptive.
Why is that?
Because the packing is similar. When we are trying to address a girl's menstrual cycle, you have to give them drugs in which will if I'm adding another flute to the orchestra, it cannot be playing another tune. It has to be playing the same tune. So here I am
and you
adding,
want it to be cyclical.
And I want it to be cyclical, and I want it to be in sync. I don't want it to be doing its whole different thing where it throws the whole cycle off. So hence the packaging of the same thing is in that contraceptive pack form, the 21 tablet pack. So also the undesired side effect of it is, as long as you're taking the hormonal drug, it acts as a contraceptive, but that is not the desired effect. The desired effect is it regularizes your hormones, and that's how people assume it is. Almost all doctors have a barrier of their own before they prescribe hormones. We don't dish it out left, right and center. We know where we need to. Sadly, what's happening is people also have their own barriers, because I, as a practitioner, am not in the habit of just prescribing. I inform that, okay, so this is how it is. This is the hormonal part of the therapy. These are the side effects you can expect. These are the benefits you can expect. And I think you need it, and hence I am prescribing it to you. But then 2 out of 8 patients, 10 patients will say, let's see another couple of months and figure it out.
But do you also have patients where their parents, especially because in a country like India, where you assume that anybody who is on contraceptive is then sexually active? And a lot of mothers, especially mothers,
no,
fathers also, but...
I understand, but
do you
most
have anything
often...
like that?
No, of course it can, adult and college going age group, it might. But what's happening is most girls are being brought to us by their mothers. So the mothers are well aware. It's not like a surprise to them that, okay, she's been suffering from PCOS for a year and now she's coming to the doctor with her mother. The mother knows. The information about PCOD is so loosely and easily available. I would like to say most information is right.
But there's also a lot of misinformation, isn't there?
There is. But what you need to understand is... you have the horde of data available to you, but what to make of it, right? That's garbage. Now, when you accumulate and make a beautiful piece of furniture out of it, that is what a doctor would end up doing. You have so much information, but you don't know what applies to you, what does not apply to you, and here you are trying to act on these small pockets of random bits that you are gathering. They might not necessarily be effective. They might not necessarily be accurate. They might not necessarily be helping you. As long as this is the case, I'm okay. But they might occasionally be harming you. This is where you cross into the dangerous territory. So I always request, when you said 70% are undiagnosed, more than 90% are overdiagnosed and overtreated, self-treated.
So is this curable, or does it just have to be managed?
PCOD is not something that you end up curing, or it is not something that you want to be curing. It is something that you want to be controlling. It is something that you want to be monitoring, and if necessary, treating. So the steps of treatment would be monitoring, controlling, and then treating. Treating comes far towards the end.
Do patients ever need surgery to get rid of?
No.
Okay.
Very rarely. For infertility, we do a procedure known as ovarian drilling. When I said you have so
ovarian
many...
drilling?
No, it's not that kind of drilling. But when I said the multiple cysts around the ovaries, not allowing the ovaries to hatch a follicle, what you essentially do is you do small keyhole surgery. Yeah, you make a small keyhole surgery, and you go and poke small holes into the ovary. Hence, the majority of the cysts are ruptured, and the ovary has space to hatch a follicle. So that's the most. There aren't like major surgery. This procedure is like a 5-minute thing. It's a daycare thing. You come in the morning and the patient goes away in the evening. It's not done loosely. It's only done for patients who have been offered treatment and yet are unable to conceive, and especially unable to conceive because they are not hatching an egg. They are not ovulating.
So does PCOS, I think we may have covered this, I'm just going back to it. Does this only matter if you're trying to get pregnant, or because you mentioned there are other diseases that are linked to this?
Yes.
If I'm not mistaken, cancer also?
Yes. To answer that, I told you earlier, infertility is the least of your problems,
so
and the most easiest, the most important is obesity. So obesity is something which today is... It's something that's worse than COVID. Most common factor for that is lifestyle. At the risk of sounding a little sexist, the female hormonal cycle is a very finely tuned, is a very sensitive...
There's a lot of variables happening there.
Right? Not that it's a weaker cycle. I not for a second, but it's a little fine.
I didn't assume you said that, but yeah.
It's a little fine. And major variations, like you go 24 hours without sleeping, or you go 2 days without eating, or some days you eat at 12 in the noon and the other day you have lunch at 5 in the evening. One day you're going to sleep at 9 in the night, and the next day you're sleeping at 2 in the midnight, and some days you're waking up at 6. This all puts your biological clock off.
Men have it easier, don't you? It's like a 24-hour cycle.
Agreed. But we are not as much in sync.
It's like we are a Swiss clock and you guys are what? Like a wind-up thing?
No, we aren't a clock itself. We are like the school bell, tong tong tong. Somebody comes and rings it once in a while and say, okay, ho gaya. But for a girl, it's a very fine thing. And in today's time, there is a lot of academic, professional, social stress, pressure around. You want to do a lot of things, and you want to cram it into a small part of your life, and you want to get it done, and that ends up causing these lifestyle challenges, the dietary choices that people make.
There's no escaping junk food in today's day and age.
Agreed, but then there has to be a
portion control.
Yes, and there has to be a system to the whole thing, right?
So like an 80-20, healthy to non-healthy. Because
as a doctor, my responsibility to say is 100% healthy. But I understand. I call it an aberration. You can have a relaxing time once in a while, but that once in a while cannot be every day. Okay, so that's one. We don't have the habit of a regular exercise schedule. Nobody does. Like,
Because
and
quite frankly, I mean,
most
exercise
commonly,
goes against every fiber of your being. Who wants to put yourself
and
through
there
that
is
kind
this
of work?
pseudo exercise of doing yoga, where you're not burning calories. It's a wonderful thing. Please do it, but don't.
It's a great stretch.
Yeah, but don't consider it as exercise. What I intend to say is, with PCO, raising your basal metabolic rate for 30-40 minutes in a day,
So walking?
burning out anything, walking, cycling, running, jogging, floor exercises, swimming, dancing, aerobics, Zumba, whatever burns your calorie. The measure I give is you should be perspiring. Men sweat, women perspire.
Women glow.
Yeah, like horses sweat and men sweat, but
Men, I believe it is horses sweat, men perspire, and women glow.
all right, let's keep it that way. So, but then you should be glowing for 30-40 minutes at least,
Okay.
5 days a week. So and stress. My standard questionnaire for my routine patient checkup is, do you sleep well? And you'll be surprised how many people have a problem there. Is your appetite good? Do you feel like attacking food when you have a home cooked meal also, but do you feel like eating? It's all a state of your mind. So the head is the brain is your strongest organ in the body. If that's going out of sync, there is no surprise your hormones will follow. Right? So that is something that forms the root of the treatment. Informing them what are the right choices they are making. The second step comes where we see how abnormal your hormones are, and depending on it, whether we need to prescribe anything or not. When you said how does it affect, if you have insulin high, which I mentioned as one of the tests you do, you run the risk of developing diabetes later. If you have an abnormal glucose tolerance right now, you have the risk of developing diabetes in an elderly age group.
Which means then also you have the risk of heart disease.
Absolutely.
And everything else.
Absolutely.
That goes with it.
Absolutely, it goes with it. Simply speaking, PCO means your estrogens are slightly on the higher side. As long as your estrogens are great, your heart risk is a little reduced. And that's why it's supposedly said women have lesser heart disease in the fertile age group, mind you, not after menopause, than men. But then with PCO comes your hyperinsulinemia, your lipids go off, and that automatically starts escalating your heart risk. And especially post-menopause, it sort of hits the roof. So somebody with PCOS post-menopausal has a very high cardiac risk involved, has a very high cholesterol risk involved. It has a very high endometrial cancers and uterine cancer risks involved. PCOD abhi treat kar diya, control kar diya, that probably helps you for the rest of your life. Most women feel PCOD tha, now I have conceived, family is over,
sorted.
Yeah, job done well.
Menopause aa jayega to anyway band hone wala hai, to kya farak
padta hai? But that's not how your body works.
It's not like an Uno reverse.
That's a nice way of putting it, but yes, it is not like an Uno reverse.
Okay, but because it's affecting your hormones to this extent, I would assume that it also affects your mental health. Is there like an added risk of anxiety, depression, PMDD, whatever?
Yes, it is. It is because of the hormones, as well as it is because of your own perceived sense of self well-being or self-worth, your own confidence. Because most girls with PCOS have slightly overweight, they have low self-esteem, they might have excessive abnormal hair or pimples or a buffalo hump, so to speak, a little thing here, obesity on the shoulders. So they are suffering from, and they are at a very impressionable age, so they are suffering from a certain amount of self-esteem issues. But as well, the hormones, because of the anovulation and the persistent high estrogens, there are going to be these phases of emotional turmoil or depressive disorders or anxiety disorders or mood swings, whatever you want to call it. And they are physiological, they are real.
It's not just in your head.
Yeah, people have the habit of saying, get on with it, it's all in your head. No, it is not. It is real, but it is treatable.
Does getting your first period really young have any effect on this? Is
No.
there any correlation?
No.
Because we're seeing girls get their first period earlier and earlier.
Because of so that has something to do with our emotional maturity, which essentially the age of emotional maturity is getting more and more younger and younger. It's something to do with our nutrition, it's something to do with our lifestyle, with our social fabric. But yes, it is, and it is alarming. The age of minority when we were studying was taught to be 13, and today we see girls as young as 10 attaining menarche, and it's not surprising, but it is not a disease. It's not
it is not, I mean, if it's happening,
it is
it's
what
happening.
it is.
Yeah,
it is what it is.
Another thing I wanted to ask you about is I read somewhere that women who have PCOD have a greater chance of building muscle faster. Now, I don't understand the science behind this, but it had something to do with the fact something about elevated androgens. It sounds a little sketchy.
It isn't exactly what you're putting it out to be, because yes, PCO has hyperandrogenism as well as insulin, which I said is an anabolic steroid. There are other things which are at play as well. Hence, it's not as straight as you put it. But yes, practically speaking, that is how it should work.
So strength training.
But anybody who has
better
hyperinsulinemia, what we have observed is if they're put on treatment for it, which is commonly known as metformin, the drug which commonly people know, and it is primarily used for diabetes, but it's wonderful in PCO with hyperinsulinemia. If a patient is put on that, they start losing weight real quick. You'll have girls coming to you and saying, I've tried a whole year and I've not been successful, and I've really tried everything, but it just budges a little and then bang, it comes back. But when you test them and you find hyperinsulinemia, and then you give them metformin, and then voila, suddenly they'll start showing all the effects. So yes, there is some fact in what you're saying, but it is to be taken in terms of what actually your hormone levels are.
I mean, and this was a popular science article, so I don't.
Yes, but
I couldn't find the original paper on it. So.
But find me a girl who wants to build muscle mass.
But shouldn't we all be building muscle mass?
A fair amount, but when you're what we are talking about here is really
bulking up.
Bulking up. That's not practically possible. I don't think so.
Is there anything else you would like to tell us that I haven't already covered?
Not that immediately strikes me.
Okay.
But
anything? Yeah. Any stories about your patients?
The commonly faced condition that I encounter is mothers coming to me and saying, "My daughter has PCOD." Imagine you're sitting in the office and there's a patient who comes in and
so they've already decided that this.
Yeah, they've already come with a decision. There's a 13-year-old girl who walks in with her 30-year-old or 40-year-old mother, whatever, and.
Is there a genetic
and he said, why did you come here? And they say, sir, she has PCOD. Alright. Okay. Exactly. Alright. So
why do you need a doctor then?
What do you want me to do? And then they say, sir, we got this scan done. Why did you get the scan done? Sir, she's feeling a little bloated and there was some lower pelvic pain and we thought we'll get a scan done. So,
but isn't that like textbook PMS?
There are multiple things wrong at things are wrong at a multiple level, but so they did an ultrasound and they were told aisa hai, and now I don't want to. The next thing, this is a good mother who actually brought the daughter to a doctor and said, I don't want to give her hormonal treatment. Can we do something else? At least she's had the sanity to come to me and ask this question. Most people would start acting on their own with all the methis of the world that you talked about, but they don't want to come to a doctor, right? At least there are some who still do, and my job there is to give them a 30-minute session and tell them at the end of the session is that prescribing would have been a 2-minute job. I have invested 30 minutes in your daughter. Please do not put her on treatment unless I ask you to. And please do these tests. Let's see the level of your disease or whether you have any of it or not. Do these changes in your life. See where it takes you. Keep her close to me. I'll be in follow-up with her. I'll see her every 3 months if necessary, every 6 months if not. But let's not put her on immediate treatment. My basic understanding is that very rarely would you need to put a girl on treatment under 18 years of age. I don't want to be the guy who gives her first hormones when she's 14, 15, 16 years of age, and essentially unnecessarily. I would like to monitor her and see her once she's 18 and above, and once she does really show some symptoms, not the pseudo symptoms of PCO, is when we would want her to be on treatment. But there aren't any stories or anecdotes that I kind of remember. Patients were very clinical, and that's how we see things.
Do you think that women are bringing in their daughters earlier because maybe they were diagnosed or misdiagnosed with PCOS? Is there a genetic component?
No, there isn't. But diabetes is a precursor, that is genetic. But majorly speaking, no. So there are so many things that have a genetic component, but then they have their own other etiological factors as well. And more often than the epidemic that it is today is more because of the other factors, not the genetics. It's because of all this the lifestyle issues and the dietary issues.
So we haven't yet pinpointed one cause, that this is what causes it. It's a whole range of things, right?
Broadly speaking, it's a lifestyle. So we've started calling it a lifestyle disease. It's soothing to the ears as well, that it's not like a dangerous disease. You've not encountered COVID. You've encountered a lifestyle disease, but then along with it also brings the understanding that what that needs is lifestyle correction.
That has been very helpful.
Thank you.
Thank you so much for joining us, Doctor. If you like this episode, tell us in the comments. If you didn't like it, tell us also why. Don't forget to share this with your friends and check us out next time. We'll be right here. I'm Marilyn Gore, and this is Benefit News.